Huda, as the treating physician, what are some important safety concerns or things for you to consider when you're looking at different treatment options for your AML patients?
So we all have to realize that patients with AML typically are quite sick, and so there's always going to be concerns about low blood counts, cytopenias, transfusion requirements, and risk of infections. So we do have to take that into account when we're looking at the toxicities of these medications. So of course, number one is cytopenias. Many of these therapies can cause prolonged cytopenias, especially those like the induction chemotherapies. And CPX 351 also causes probably even a longer duration of cytopenias than the standard induction 7+3. The other types of toxicities, some of them are more unique. So we all know that treatment for APL, there's risk of differentiation syndrome, and we now see that some of the newer targeted therapies, especially the IDH inhibitors, but even the FLT3 inhibitors, can cause differentiation syndrome. And so we need those that are prescribing and taking care of these patients need to watch out and monitor their patients closely for the risk of differentiation syndrome. And typically these patients can have fevers, they can have volume overload, shortness of breath, and sometimes increasing white blood cell count. The other more common types of side effects, especially from cytotoxic therapies, are things like tumor lysis syndrome, which most people are accustomed to monitoring for that in acute myeloid leukemia. We monitor labs very closely. There's for example, venetoclax, which typically is supposed to have a high risk of tumor lysis syndrome and some other hematologic malignancies. We don't see that very often in AML. However, we do have to be really cautious and monitor for tumor lysis syndrome and also prophylax them with allopurinol.
And I think it's important to note too that since some of these are newer agents and we're treating patients on an outpatient basis as well, that counseling patients and telling them what to expect and what side effects to look out for is really important.
And we typically, when prescribing these medications, when we're reviewing these medications with patients, especially in the outpatient setting, we're discussing it with the physician, sometimes with nurse practitioners, and the pharmacists as well. There's certain dedicated outpatient pharmacists in the clinic as well as in specialty pharmacy that typically either see the patients in clinic in person or over the telephone, going over these specific side effects.
We mentioned that one of the big risks in this patient population due to having prolonged cytopenias will be risk for infection. And now knowing there's a lot of oral agents on the market, Amanda, can you comment a little bit on how you guys have managed your drug interactions with different agents and your choice of, specifically we definitely think of azole antifungals right away when anyone says drug interaction.
Yeah, so at our institution, we generally like to prophylax against fungal infections with azoles. Our drug of choice generally is posaconazole. However, specifically venetoclax comes to mind where there is a significant drug interaction. So what we've done is we try to use isovoconazole whenever possible, but sometimes you struggle with getting approval on the outpatient setting for that. And then we do have pharmacists who are monitoring patients and dose adjusting ahead of time to try and manage this interaction. Now, we drop down to a dose of 100 generally when we have a strong CYP3A4 inhibitor, but it's nice to know that even if the effective dose were to be higher, we do have safety data all the way up until 1,200 milligrams for venetoclax. So we generally are able to manage, and patients have been able to manage those side effects.